Dr. Mokdad, thank you for talking to us again. Let's start at the beginning. I know you've explained this already, but the last time we talked, we were looking at a projection of about 66,000 deaths by August 4th, and now we're above 130,000. I don't know quite where we are today. And there's a reason for the way the projection changed. Can you explain what happened?
Yes, good afternoon. The reason for this increase in projections from the last time you and I talked is increase in mobility, premature relaxation of social distancing. We are seeing now more and more presumptive deaths being added to the total mortality, and we have seen several outbreaks of COVID-19, especially in the Midwest.
And when you say mobility, you mean just people moving around?
Yes, we have noticed right now that we are using mobility data that people started moving even before states relaxed their social distancing measures.
And now that they are being relaxed, then we're getting increase from even that.
Exactly. So if you, even in our state, if you look in our state in Washington, we have seen a decline in mobility to minus 56%. And now it's went up about 4%, even before any relaxation.
So just as a citizen, here's my question. We know the virus hasn't changed. It's still terribly contagious. It's dangerous. We don't have enough testing. We have no national plan for testing. We don't have a cure. We don't have a vaccine. And states are starting to reopen, as you mentioned, in your opinion, prematurely. Where are we going?
Unfortunately, and depending where the state has opened prematurely, the rate of infection will go up. So states who are still leveling and opened up are at a higher risk. States that were coming down and opened up are a higher risk, but not as much. So what we are heading towards is an increase, unfortunately, in circulation of the virus. We will see it in a week from now because some of them relaxed a week ago. It takes about 2 weeks. We'll see an increase in infections, and unfortunately, 1 week later, an increase in mortality.
As you look at this as a health expert, what do you make of the policies, given what you've just told me about the sheer math of this?
Wow, it's a premature policy change, in my opinion. When you look at the data is telling us we have to be a little bit more patient. I understand the balance between going back to work, but also we need to keep in mind saving people is more important, in my opinion, of course, and everybody's opinion. And of course, reducing the burden on our hospital is very important.
If we continue pursuing testing in the way we are now with no national plan and governors trying to do this on their own and competing against each other and then other federal entities, will we ever get to the level of testing we need to?
Eventually we will, but how long it will take us to get there. So that's the problem here. Right now, we don't have enough testing, and we are increasing our capacity of testing everywhere. Almost every state is. So that's good news. And testing right now, because we have more testing than we had before, we are able to detect cases earlier. Now we're testing people who are not sick. So we have more tests. And by catching somebody earlier that he or she has COVID-19, we're able to do the tracing and the isolation. So we will reduce the number of COVID-19 in the future and number of deaths. But yes, we are concerned about testing, and we are not there when it comes to testing.
If I wanted to go out today and find out if I'd had COVID-19 already, because I had bronchitis in March, or if I wanted to find out if I am a silent carrier, could I do that?
It depends where you go. Some places can do it, some places can't in our state. Our lab capacity at the University of Washington is increasing, and we expect we will be able to do 10,000 tests a day. So we are getting there. Unfortunately, for testing, you need the materials for the test, and we are short on some of them.
What are we short of still? I know that we were short of reagents at one point and swabs. What is it?
Reagents and swabs, yes.
Okay, let's talk about vaccines. I know New York University had some information out in the days past. Where do we stand? Who has the best chance, do we think, of getting a vaccine? And reasonably, I mean really reasonably, when would it happen?
You know, it's premature to tell what vaccine will work or not. Some of them are still, most of them are still in clinical trials, and they're different phases of the clinical trials. Even if we have a vaccine, Margaret, by January, which everybody is saying the luckiest would be January, we need 8 trillion doses of vaccines because everybody in the whole world is susceptible. Just producing that amount and distributing it is a nightmare, as you can tell. And we have seen right now, even for testing. So right now, I'm optimistic that we will get a vaccine. Will we get it in time before the next flu season and the next COVID-19 season? That's a big question mark. The good news is in the United States government is investing right now and paying some of the companies who are working on a vaccine to start the production. Even if this vaccine hasn't been approved, starting the production will give us more time to have vaccines at hand once that vaccine is proven to be effective.
I've heard, though, that we have shortages in the things that we need. Assuming this is an injection as opposed to a patch or something else, we need syringes, we need rubber stoppers, we need vials. If we're going to send it overseas, we need to protect the cold chain. Are we in any way prepared to do that?
No, not to that level, unfortunately. But, we have time to prepare, and we should invest a lot of time in preparing and use our experience with previous vaccine and cold chain. And also, you're quite right, the supplies in order to provide this vaccine and the skilled people to provide this vaccine. We don't want to reach a point that we have the vaccines and we don't have people who can vaccinate.
If we stay on the path we are on now, as you said, in your opinion, premature opening and a spike in all of this, we know the fall will bring regular influenza. What do you think we're looking at? What should I be prepared for personally? What should other people be prepared for?
As I said in my piece, we have several factors that we can look at as we move forward. One of them is heat. We're noticing a small effect of heat, and we're hoping that with temperature, as it gets warmer, that effect will be stronger. So on. Two, as we said, we have more testing right now. And by more testing, we can reduce the number of infections. So these two are working with us and in order to reduce the infection rate. Mobility is the one we are concerned about. So the message here is if you are getting out for one reason or another, again, what we have talked to you and I before, protect yourself, protect others from you by wearing a mask and keep a safe distance from everybody else. So that will help us. So if we don't practice, these are balancing each other. If we don't practice the safe distancing and we are increasing our mobility at a faster rate, then we are going to see a spike in cases again and an increase in mortality, unfortunately.
Let's talk about things like schools, how we're going to make decisions about whether school resumes in the fall or if there's summer school. What are the measurements that will go into those decisions?
What we're looking at right now, again, it's case-by-case basis, depending on the physical space itself. We're looking right now at lowering the infection rate to a level that we feel the public health system can detect, trace, isolate. And then we talked before about one prevalent case per million in the population. In our state, that will be 8 cases a day. We are right now detecting about 200 cases, a little bit over 200. We suspect they're about maybe 5 times that because we're not testing everybody. So we're not close to any decision of opening schools. And again, this virus is in charge, unfortunately, right now. We have to wait and be patient, contain our urge to go back to normal, the new normal, until we can control this virus and its spread in our communities.
Well, there's a pretty huge difference between 8 and 200 or 5 times 200. We're not anywhere close.
Yeah, but it's coming down. Remember, we are coming down. So that's a good sign. So we're coming down. We're heading towards a controllable measure. Now, we could come in our state and increase the number of tracing, the number of testing. We could do more than 1 per million. Again, but we are being very cautious here and saying we should not open businesses back to normal until we are confident that our public health system, that it's already stretched as is right now, to be able to do what they need to do in terms of detecting the cases, tracing them, and isolating.
Well, let's think out. I know you're doing modeling, you're doing science, but let's talk about social life just a little bit as we stretch this out. There's some things that look to me like they're going to be semi-permanently changed. We're wearing masks and we're doing that. I wear mine to keep other people from getting sick. I want to high five. I virtually high five those who I see in a mask because they're trying to protect me. But I think about shaking hands, going to sporting events, a crowded park, all of that. Are we looking at a change of lifestyle that is going to last here for months and maybe years?
Yes, unfortunately, until we have a vaccine or a drug that's effective against COVID-19, we're going to change our behavior. That's why we say the new normal. Yes, hugging, shaking hands, being in close proximities is not going to happen soon. And yes, we're just having these discussions at the University of Washington. How could we safely open our university and bring students? And as you know, we have moved all our summer classes online, and we are now talking about fall. So sometimes in September, end of September. So we are prematurely looking at opening up. And also when we open without a vaccine and a medication, we are going to be very careful, and we're going to change the way we live and the way we practice our daily routine.
So pretty much everybody needs to slow their roll.
Exactly. So my guess would be all of us who can work from home will be asked to work from home. People who can't work from home will be relaxed the measures to go back to work, but they have to do it safely. And we have to look at the physical space of every position we have, every factory, and make sure that people can be apart or have a barrier between themselves so there is no spreading of the virus.
I'm worried I'm never going to get a hug again.
This will go away, but we have to be patient. No, and I'll be the first to hug you when I see you, and we'll have this interview face to face. We all need a hug every now and then. We smile, you and I, when we talk, we smile, but we cry sometimes. I mean, we're losing a lot of, these are not statistics. 134,000 is not a number.
Yeah.
These are human beings that have loved ones, have friends, and have family. So it's a sad story. But I'm confident we're going to get out of it, and then we should do it right. We have a chance as we rebuild our country and roll out the stimulus to make sure that we don't leave anybody behind. And yes, we should come out of this stronger. And all those people who died and sacrificed their life, all the people who lost their jobs and incurred a lot of financial cost, their sacrifice didn't go for nothing.
Let's talk about older people. We talk a lot about elders being vulnerable, and we know that we had the terrible situation in the assisted living care home here in Kirkland. What does older mean? At first, we sort of understood this to mean elderly, maybe 70s, 80s. I've heard people say 65, 60. Governor Cuomo mentioned older than 50. What does older mean in terms of vulnerability?
So right now we're saying older is 65 and above. That has been always a high risk area. And now for COVID-19, we're even lowering that. We're saying 50 to 65, 55 to 65 as again, as another group. For the older population, this has been tragic. And for all of us staying at home, there is a cost also for staying at home. On our emotion, on our mental health, on a lot of things. I mean, we want to be productive, we want to be out and about. So there is a big financial and mental health and physical and mental as well. But also for older population. I mean, I have a mother who is in an apartment in Beirut, Lebanon, hasn't seen anybody in the past 2 months. If my sister goes to her apartment, she drops the food and then she leaves, because she is a high risk. She had an open heart surgery, and we are very much concerned about her. So here is nice, somebody at this age who's happy, still very healthy, and can move around and can take care of herself. Her grandchildren are not around her. She cannot see her children. She cannot hug them. So it's very difficult.
Very difficult. I want to talk about this term herd immunity, which I don't particularly like since we're not a herd. Maybe we can call it population immunity for the purpose of this discussion. Is that a legitimate goal?
No, I don't like the term herd immunity, not because of population or not. For me, herd immunity means failure. We have failed to deal with this virus, and we decided to let somebody be infected and let some people die. And if you look what happened right now in New York, if you look at New York City, for example, 21% are positive for antibodies. So 21% got the infection. Look how much it cost New York City to be where they are at 21% level. So imagine if we want to go to a herd immunity of 80 or 90%, we cannot afford that. We cannot afford 100,000 deaths, let alone much more than that.
Where would you say Washington State is right now? How would you characterize our situation?
We're doing very well in our state. And unfortunately, as you and I know, we had the first case and we had the spread in the nursing home. So We were caught by surprise. The virus creeped here and was circulating before we were able to detect it, unfortunately. But we took the right decisions and we closed as early as possible. That has helped us. So right now, infection rate is coming. I mean, we had like about 490 cases at one point of time. So we're coming down, and it's coming down at a rate that is acceptable to all of us. We feel like the light is at the end of the tunnel. We see it. We're not out of danger yet, but we're heading into the right direction. And that's why you and I and the governor and everybody else were able to talk about opening up and what the strategy we should use. So we have achieved a lot by closing down fast. And in my opinion, we're going to come out of it faster than other states. And we are going to recover our economy faster than other states.
What gives you hope?
People like you, people. It's very hard. People have been very good.
Maybe that's what will come out of this. An appreciation for one another and our mutual humanity.
Yes, I hope so. Yes. Americans have been the true heroes here.
Bless you. Thank you for the work you do. Thank you for spending time with us.
Thank you.
All right.
Be
Talk
safe.
to you again soon. You too.